we have a panel discussion on indication of radiosurgery in Pakistan, for which I request the organizing committee members, Dr. Muhammad Waqas Baqai and Dr. Ahsan Ali Khan, to take over. Dr. Ahsan and Dr. Waqas, over to you.
Thank you, Basil. So before we start the panel discussion, I just wanted to ask one quick question from Dr. Melhawi, because this Dr. Heather from King Faisal Specialist Hospital and Research Center in Riyadh is asking about his experience of treating glioblastoma using radiosurgery in a deep-seated lesion. So if you can comment, then we will move on to the panel discussion.
Yes, thank you. So for glioblastoma, I think all of you know the prognostic and the protocols. So still with the applied protocols, there is no solution for cure. So if you consider the guidelines, radiosurgery is mainly a second line option when you have focal resurgence of the lesion, and can be of help also as boost in the primary. So we have more or less two indication, but of course it's not the primary treatment option. Thank you.
Thank you, sir. Okay, so now we will move on to the panel discussion. And so the topic of this discussion is indications of radiosurgery in Pakistan. I'll just go over the quick introduction of our panelists. Dr. Kamran Saeed is a radiation oncologist, and he is leading the CyberKnife Robotic Radiosurgery Unit in Jinnah Postgraduate Medical Center, Karachi. Dr. Abid Saleem is a consultant neurosurgeon and head of the Dow Gamma Knife Radiosurgery Department at Dow University of Health Sciences, Karachi. Dr. Adnan Jabbar is a medical oncologist, presently working as an associate professor and section head of medical oncology at Ahsan University, Karachi. Dr. Asim Hafeez is a consultant radiation oncologist and assistant professor at the Ahsan University Hospital. Dr. Ather Enam is a professor of neurosurgery and the chair of the surgery department in the Ahsan University Hospital, Karachi. So to start this discussion, I'll just quickly ask one question and then we'll move to Dr. Waqas to share some cases. So I want to start with Dr. Kamran Saeed, if he can give us his comments about the most common indication in Pakistan, in his experience that he has seen for the radiosurgery. Keeping in, and sorry, yes.
Assalamu alaikum. Basically, we are doing radiosurgery since last 1 decade, and majority of our cases were intracranial pathologies, and almost all of them, but they had initial surgery followed by our opinion for their treatment with SRS. Majority of our cases were meningiomas, AVMs, acoustic neuromas, schwannomas, paragangliomas, craniopharyngiomas. Every pathology that is in the textbook we have treated as per guidelines.
Thank you, sir. Dr. Waqas, you can share the screen and just start discussion of the cases.
Thank you, Dr. Hassan. So I'll just share some cases and then we can have a discussion on the probable utility of stereotactic radiosurgery in those cases. So to begin with, I would first like to thank all the panelists and we can start our discussion. So this case was a very interesting case that we came through last year. So just to give you a brief history, this was a 24-year-old right-handed female presented to us with signs of raised ICP. I'll skip to the MRIs. Her MRI showed a right temporal lesion, which was contrast enhancing. And then she underwent craniotomy and goscopal dissection of the lesion. The post-op MRI, as you can see, showed post-surgical changes. On the left is the pre-contrast and on the right are the post-contrast images. And these are the post-surgical changes that are intense on both the pre and post-operative pre and post contrast images. Again, the same thing. So a standard CCRT was given, and then she was followed up sequence with serial MRIs, and 6 months post of MRI was done, which showed this another lesion in the left CP angle, which was not there previously. So it was surprising to us as well. But seeing the mass effect and the size of the lesion, still we planned retrosigmoid craniotomy and dissection of the lesion. We got the post-op MRI, which showed again a gross total with post-surgical changes and some intensities near the brainstem. So she was then followed up with serial MRIs, and again on 3 months follow-up MRI, there was again a lesion in the left CP angle on the same site where the previous lesion was there. And I forgot to mention the biopsy of both the lesions was GBM. So now at this point, multidisciplinary tumor board meeting was set, and the case was discussed in details, and it was suggested that maybe we can go for SRS. So this was the pre-SRS scan. You can see the lesion, even this was within the 6 months of the surgery. And then as per the tumor board discussion, she went for chemotherapy along with stereotactic radiosurgery. And this was 3 months post SRS. You can see that there was a significant reduction in the mass effect, the perilesional edema, and also her symptoms got better. So, Doc, I would like to have some input from Dr. Abid Saleem on this case in specific and in general for the utility of SRS in GBM, like after CCRT and all.
Yes, can you hear me?
Yes, sir.
Yeah, it's the case which you presented is you have already depicted the role of SRS in recurrent glioblastoma. Because in recurrent glioblastoma, there is no standardized treatment available. So institutions are treating it according to their own experience and availability of the devices. So the role of gamma knife, because I'm working gamma knife since last 14 years. The recurrent GBM is a good indication for gamma knife, and it shows a good initial response. So anything which is where we can do a focused radiation, a smaller recurrence is a good indication for recurrent glioblastoma. And there are other accessory things to it, like the use of like bevacizumab along with the stereotactic radiosurgery. Because if you give a dose of bevacizumab, the enhancing portion will decrease, and you can target a lesser diameter lesion with it, and you can use the bevacizumab in the follow-up also with a better result.
All right. Thank you, Dr. Abid. Dr. Adnan, what are your views on it? I am assuming that you may remember this case, and yes, he is on chemotherapy. I know. So, what do you think what do you think about this case?
Well, first of all, thank you very much for inviting for this panel discussion. Yes, very amazing, very interesting case. This lady, had failed all systemic therapies. After her first recurrence, we did put her back on temozolomide. She failed that. She went back on bevacizumab. She failed that, and that's when we had this progression. And when we were talking about SRS, one of the questions that came, and in fact, Dr. Kamran convinced me that we needed to put her back on bevacizumab. And mind you, before that, she was on carmestine because we had given her third line of treatment, and she was progressing. So we had pretty much, ran out of all options. SRS along with bevacizumab worked wonderfully for her. we have continued giving her VEGF inhibitors after her radiation. And to date, she is not only maintaining her performance status, in fact, she has regained some of her performance status in terms of her ability to walk, communicate, and things like that. So I certainly believe that SRS do have a role. It is a selective role. We need to be very cautious, and certainly our patients can benefit from that.
Thank you, Dr. Adnan. Now I would like to ask Dr. Kamran Saeed that what is his experience with recurrent GBMs, and how do you think that patients with recurrent GBM can benefit with SRS?
In fact, this is the case that we treated at our center. She is a young lady and a very loving husband. And she was referred to us a year back with a CP angle relapse, which was biopsy proven, and we treated that lesion and with a very high dose of SRS, and there was a very good response. We also gave her Avastin day 1 and day 14 for that particular lesion, and she was quite okay. But unfortunately, on our very first follow-up, there was this second lesion that developed almost 2 to 3 centimeters below the lesion which we treated. And you can see that it is almost in the medulla and the upper cervical lesion. And I talked to Dr. Ather Enam and Dr. Adnan Jabbar about this particular case. And due to non-availability of any systemic options, we gave her second SRS dose to this lesion. But we strongly asked the family to continue Avastin for at least 3 to 6 months so that undue side effects could be avoided. So Allah has been very kind and turned out to be a very good decision. And patient we saw her a couple of days back, and she has responded very well to both SRS.
Thank you. So I would like to ask Ather for his input on this one.
Thank you for seeking my opinion. So yes, this is a very unusual case, and the family and the patient has been very resilient and very cooperative. Amazing family and amazing patient also. So actually my question is not about this case, but in general, my comment is that a lot of times I find that in certain locations, as a neurosurgeon, I feel very reluctant to go in there because the risk of complications are high. But in the same cases, when I request my radiosurgery colleagues, they also show reluctance because they also are afraid of that radiation isodose curve falling onto some sensitive parts of the brain may cause damage. So a lot of time it comes to I wouldn't call it loggerhead, but it comes to a sort of a stalemate. What should we do? Should we take the risk in the surgeon's hand, or should we take the risk in the radiation oncologist who's doing the radiosurgery in his or her hand? And here's a case where I basically said, if I go in there, I will cause much more damage. And Dr. Kamran Saeed agreed, and he proceeded, and we saw a good result. And there's a similar case I remember for meningioma, which was pushing on the carotid artery, actually engulfing the carotid artery and pushing on the optic nerve. And that patient is also doing very well after radiosurgery, despite the fact that we were afraid either surgery or radiosurgery could cause harm. So I think we need to come up with some kind of algorithm where we can stratify the risks that a surgeon thinks and the radiation oncologist thinks. And based on that, based on that, we should decide. Because many times what happens is just an effort to try to convince one or the other that, this is high risk, I won't do it. No, this is high risk, I won't do it. So I'm just putting it in front of all these, wise and intelligent people over here, that we need to come up with that kind of algorithm where we can say, look, if a surgeon does it, this is the risk. If the radiation oncologist does it, this is the risk. We can't just use a figure of the risk, because when you say in 100 cases this is what happened, that still does not really tell you what is the risk to that one particular patient, because every tumor is different. So I don't have an answer for that, but I just wanted to put it to this panel, to what are their thoughts. Maybe Dr. Abid Saleem may suggest something, or somebody.
Yeah, it's difficult to make an algorithm which is true to all cases, but what I can comment is that for a deep-seated lesion, if you compare surgery and stereotactic radiosurgery, the side effects or post-treatment side effects will always be less in SRS than in open surgery. Because the open surgery has its own standardized side effects and complications, which we can all of them provide in non-invasive kind of treatment. So there is one thing, and then there is our personal experience with various diagnoses and locations and the tumor size. So it's better to discuss an individual case with your colleagues and other centers, that what is their input in that at a personal level, rather than sending the patient. You can send a message or email or WhatsApp and discuss with the treating radiation oncologist, and you can discuss what is your point of view, what is your complication set, and what is our complication set. So whichever is less, that should be offered to the patient.
So the issue actually is, probably there's no answer to this, because this is the same issue that has plagued clipping versus coiling. I mean, one person says that, so there are certain cases where it's very clear cut that this will have a high complication, this will have a low complication. So that does not need this kind of algorithm. And I don't think an algorithm can exist for this kind of thing, because it's every tumor or every aneurysm for that matter is different. And you can't give put a number to each of those cases. When you discuss it, again, we don't know what is more complex. I'm talking about those cases where we feel that the complications can occur with radiosurgery, and or complications can occur with microsurgery. So this case actually falls in that category. If I go in, I will cause damage to the lower cranial nerves. She will end up with tracheostomy and PEG, and because the tumor will still be wrapped around all those nerves. That's what we saw initially when we were doing it. And from radiosurgical experts' perspective, it's stuck to the medulla. I mean, there's just even if you go for a couple of millimeters, and you can cause significant damage to the long tracts. So it's very hard to really differentiate and say what answer is correct answer. But you're right, the discussion has to be done anyway. And in that discussion, whoever convinces whoever is what the answer is, and probably we will not know the answer. We can't bring an AI based algorithm to this.
Can I ask a question? Sorry.
We can bring an AI based. So what we can do is all these different places, we keep on adding them, and we will be able to get an algorithm out of it. So that goes to Dr. Kiran. So what we do is, it won't happen here. It will happen over many years. We just keep on collecting these cases, and feeding the information, detailed information, and get the outcome at 1 year or 6 months or 2 years and so on. And then we may come up with the right algorithm. So I take my comment back. Sorry, please go ahead, Dr. Hassan.
So I just wanted. Dr. Kamran, yes, sorry. Yes, you go ahead, sir.
My take on this topic is that what I feel with my personal experience, that state surgery or microsurgery is a gold standard, and we should these patients should only be referred to a radiosurgery only when a surgery is not possible, or whatever the consequences, whether due to his surgical complication or location, whatever is. But surgery should be a gold standard, and neurosurgeon should first decide whether this pathology is doable or not doable, and then refer this to a radiosurgical center. Because with radiosurgery, we can do anything. There's no, I don't find any pathology that could not be dealt with radiation. But we must adhere to the principles of treatment, and that I personally think that surgery is the first modality that should be dealt with, and other, if not possible, then role of radiosurgery comes into play. That's my take of this point.
So thank you, Kamran, and directors of this session for mind too much. Dr. Hassan and Dr. Waqas, please excuse me for doing this. So the thing is, in surgery, it's not doable or non-doable. Just like radiosurgery, in surgery, everything is doable. So you can go in there and you can take care of this lesion, for example, in here. You can remove it, and then the complications will be lower cranial nerve damage or maybe some other neurological deficits. So it's not black and white, it's not binary 0 or 1, it's a shade. And at what shade you say that this is too much or this is too little, and at what shade in radiosurgery you say, okay, this one is darker, this one is lighter than that. So thank you for saying that the microsurgery is the gold standard. But then microsurgery, any surgeon knows, just like that it's not black and white. There are shades of gray in between. And I think that's where probably an artificial intelligence based on deep machine learning, the algorithm, AI-based algorithm would help in these kind of cases, where you can just feed this information and the number pops, the number comes out that, okay, so much risk with this kind of region, with this shape, with this position and all that thing, with this age and all that thing, with radiosurgery or with microsurgery in certain surgeon. And then again, you put in the surgeon's background also, what is the experience of doing these kind of cases. So again, I'm leaving this whole thing unanswered. But then that's what true science is. A lot of things are unanswered. Please go ahead with my apologies.
So I just wanted to ask Dr. Asim if he can also comment, on the patient selection. So when it comes to the patient selection, and for example, in these patients where conventional radiotherapy might also have role, how do you select and when do you refer or suggest the patient for the radiosurgery rather than moving on with the conventional radiotherapy?
So thank you very much, Ahsan. So the important point, as discussed earlier by all the panelists, it is actually the role of this. We all actually are afraid of the consequences of the treatment. That is the main point. So like these difficult cases, the always remain unanswered. So it is a very difficult situation. So for this particular patient, when we are talking about the conventional radiation therapy, it is very beautifully described by Dr. Mali in his presentation, that when we are talking about the conventional radiation therapy, the radiation dose spread is much greater as compared to the stereotactic radiation therapy. That's why this patient, although for this patient, the tumor site is a new one at Ather site, but it is still very close to the initial one. and the brainstem itself is actually received the dose. So if we proceed with the conventional radiation therapy, then it is very difficult to actually control the doses to the critical structure that I've already mentioned, that about the brainstem and the cranial nerves and all these things. So that's why for this typical situation where you want to confine to the tumor as much as possible and to spare the normal structure as much as possible. These are the indication for stereotactic radiation therapy because as already mentioned or discussed in earlier, you have also asked a question from Dr. Malavi regarding the role of stereotactic radiation therapy or stereotactic radiosurgery for particularly in GBM. So there is no upfront data regarding the role of stereotactic radiosurgery in upfront setting. However, in recurrence, yes, one can consider, and a situation like this that the case we have discussed. The other thing, as mentioned, that for this type of situation, typical situation, the other very important thing is about the multidisciplinary meeting that we have discussed earlier. I fully convinced and I'm fully agreed with Dr. Malavi's presentation, which have said that MDT is the way to move forward, because this issue we all have our technical difficulties, expertise, limitations. So we have to realize that, but we have to move forward as well. So MDT, peer review, all these things would be actually the way to forward. So question to your so answer to your question is regarding the first selection of particularly this for any patient that require conformity, need to be proceed with the stereotactic radiation therapy. Thank you.
Thank you. Waqas, I think you can move on to the next case.
And before that, I think Dr. Adnan wanted to ask something in the beginning. Dr. Adnan, do you have that question still?
No, I think I'm good. Thank you.
Okay, so we'll move on with the next case. So this is about a 43-year-old with no known comorbids. He presented with decreasing vision bilaterally for 2 years. And sorry, I did not have the MRIs, but the CT scan is pretty good to show that there was a huge lesion in the sella with suprasellar extension. It was hormonal workup was negative. It was a non-functional pituitary adenoma, for which we did an navigation guided endoscopic assisted transnoidal resection of cellular occupying lesion. This was 6 weeks post of MRI, and it showed some residual in the sella. So after that, he was referred for stereotactic radiosurgery, and you can see that although not all the lesion is gone, but there is significant reduction in the size of the lesion. So this is a typical case of pituitary adenoma that we often refer to the stereotactic radiosurgeons for the SRS, because many times it's not completely resectable due to adherence to the carotids and the chiasm and whatnot. So I would like to ask Dr. Malavi for his experience in, post-surgical residual in the pituitary adenoma cases.
Thank you. So again, for pituitary adenoma, as you said, most of them are treated after surgery, almost because of the need of decompression or the need to control secretion. But then when you have residual, usually, again, you have to consider, is it functional or non-functional? What is the situation of the optic pathways and the vision? And then, of course, the age of the patient. So anytime you have a young patient with a residue that can, again, be threatening for the optic pathways in the future, or you have a residual high function of the pituitary function or endocrine dysfunction, then of course these are for us indications of radiosurgery, which is clearly in the pituitary a very good adjunct to the surgery, which is of course the primary treatment options.
Okay. So Dr. Abid, want to say something?
Yeah, I just wanted to say hi to Dr. Adil because I visited their center a few years back in Alexel Gamma Knife meeting they hosted. And it's a beautiful center, and it was nice to see their struggle to give to arrange Gamma Knife for their country and then running it successfully. He was actually a very right person to give a presentation to the Pakistani audience because of the medical and the social background of both countries are the same. So thank you, Dr. Adil, for your nice presentation.
Thank you.
Thank you, Dr. Abid, for your comment. Dr. Kamran, what do you think or what challenges do you face, or what things are you cautious about while planning for SRS in pituitary cases? Sir, you are mute, I think. We cannot hear you.
Sorry, my apologies. The most important structure involved in treatment of pituitary adenoma is the optic pathway, and that for a non-functional one, we can treat even if a tumor is even abutting the chiasm. But for a functional one, we have to be very careful because we have to deliver a little bit more dose to the tumor, and in the meantime, we should save the optic chiasm. So optic chiasm is the most important structure involved in the SRS treatment of a pituitary adenomas. And I tell you one thing, that post-SRS pituitary hypofunctioning, hypopituitarism after radiosurgery is not that high, but we commonly think about or discuss in our MDTs that the physicians are afraid that if the patient will go SRS, there will be high probability of hypopituitarism. I tell you that with our experience, post SRS hypopituitarism was at least 10%, not more than 10%, in almost more than 400 cases we treated at our center. That's all.
Right, sir. Thank you for that input. Yeah, Dr. Abid, you want to say something?
Just on the same line, the functioning adenomas, what we have seen is functional adenomas are really the small ones. So you'll get an ample space from the optic chiasma in these cases. And the additional higher dose that is required can be easily placed with the gamma knife, as beautifully shown by Dr. Adil with the new software algorithms. So we have very good results giving high dose to acromegalic patients, both radiological and the hormonal response we have seen in initial 6 months, the first initial 6 months, and then it is sustained.
So, Dr. Abid, you are saying that about the functional pituitary adenomas?
Yeah, about functional pituitary adenomas, we are having good results with the gamma knife. Yeah.
Okay, so you were able to achieve the biochemical cure that our books mention a lot.
Yes.
All right. All right. Thank you. So with that, I will just show a few more cases courtesy of Dr. Kamran and Saeed, who sent me these images at the very last minute. Thank you, Dr. Kamran, for that. So these are just few examples for pre-SRS and post-SRS for pituitary adenomas, and we can all see the magic Dr. Kamran Saeed does there. So with that, I would like to ask Dr. Ather for his opinion in that when does he refer his patients for SRS for transsphenoidal surgeries, and what he thinks is the right time to do that.
Sorry, are you asking me?
Yes, sir.
Okay. So for the pituitary, this is typically, and actually, I have come up with a score of giant pituitary adenoma, and here's a giant pituitary adenoma, and their score predicts the residual volume, and the score predicts the kind of surgery or the number of surgeries that may have to take place before it becomes a small residual volume. So my goal in pituitary surgeries is that you leave, if you have to leave, well, you should remove as much as possible, but then postoperatively you find that there is some tissue left, and the tissue is typically that where it is attached to the optic chiasm, or at least next to it, and I wait for that tissue to settle down, the tumor tissue, and if that is significant, then one can go for radiosurgery at that point. And if it's not significant, then maybe it is embedded in the scar tissue. So what I do is follow them up with serial MRIs over time. And if at any point I find that it is starting to grow, that's the time when I send for restorative radiosurgery. But typically, I ask the patient to get an opinion early on, so that the patient is mentally ready if the SRS has to be instituted at any point. So the two things that are important from my perspective is that there is minimal residue, if there is a residue, and number two is that residue is not right next to the sensitive or delicate parts. I mean, the whole brain is delicate, but we're talking about optic chiasm, for example, or the pituitary stalk. So it's separate, a little separate from that. Those are the cases that I think would be ideal for SRS. I would like to hear the opinion from the other end also, that when the surgeon sends them over, what are the things they are looking for. We do discuss a lot of cases, but then for the audience, it will be good to have that discussion again. Thank you.
Yes. Dr. Abid, would you like to say something on that?
Yeah, regarding the pituitary adenoma cases or any lesion which is near the optic pathways, it was actually John Adler, the inventor of cyberknife, who presented his first paper of giving 5 gray in 5 sessions with the cyberknife, and showing that this schedule is very well suited for or to the tolerance of the optic pathways. So that also gave us an impetus. So when ICON came, we are treating these lesions in 5 sessions. Total 25 gray in 5 sessions are having the same results. So with the fractionation, now we have more choice of lesions which are nearer to the optic pathways. We can save the VN and also get a chain technique. The fractionation is further helping us.
Right, sir. So with this, we'll go to our next case. So this was about a young male with history of imbalance and reduced hearing from the right side. The MRI showed this lesion. This is not our case. This was from Dr. Kamran Saeed's library. So with this, I would like to ask Dr. Kamran Saeed, when does he think that vestibular trauma is fit for SRS, even before surgery, or just consider SRS right away vestibular traumas? I know that's the most common question that might have been asked to you, but for the sake of discussion.
The 3 most important things that one should consider before treating an acoustic neuroma is, number 1 is age. If the patient is of younger age, then surgery is the best modality, because patient has to go a long follow-up. And if the patient is old one, then radiosurgery is the best option. The second point is the size cutoff. There is mention in some textbook, it mentioned that 3.5 centimeter is a cutoff. Some say that 3.7 centimeter. Size does not matter. It depends upon how much pressure it is causing on the adjacent critical structure and what are the patient's symptoms are. And third, and the most important thing, is the hearing ability. If the patient has a good hearing ability, then SRS is the best option available to the patient. So age, size, and hearing is the 3 most important parameters one should consider before opting for any modality that should be offered to a patient.
The other thing is, I have seen when I was working with the SRS specialists like you and another, that, for example, if it's a cystic in nature, then you suggest that surgery may be appropriate. The size may not be very big, but if there's a significant compression of the brain stem and it's causing symptoms, that's also used. So clinical condition, cystic nature, those are the things. But the vestibular schwannoma is one of those very few lesions that do not require the histopathology or the histological diagnosis. This image actually is not so classical for vestibular schwannoma. I do see a slight hint of enhancement getting into the internal auditory canal, and I'm sure on the next cut it would be much more obvious. But that's a point that needs to be understood by majority of neurosurgeons across the country, and I'm very disappointed by majority of neurosurgeons across the country. They have no understanding of when radiosurgery is indicated. I've seen patients, and I have cases after cases, I've seen patients being referred for radiosurgery where there was no indication. 6 centimeters low-grade glioma, no indication. I even saw a patient that was being referred for stereotactic radiosurgery. It was an arachnoid cyst, for God's sake. I mean, and I say that, those people need to go back to medical school, or at least do some more reading and understand. And I'm glad that the interaction that I have had with the specialists in radiosurgery, they follow those guidelines, they follow those ethical principles, and they don't zap anything that comes their way. But then there are opportunities where you can just do radiosurgery on cases where it's not indicated, because it is so enticing to the patient that, look, there will be no surgery, and we will zap it up. And then I have seen so many cases where it was done wrong, it was not supposed to be done, there were complications, problems. So I think those principles apply to acoustic neuroma, except for that one where you do not need a histological diagnosis. This is one of those lesions. If you see enhancement in there, in the auditory canal, it's a vestibular schwannoma. There can be other lesions in the CP angle region, like a meningioma. And my recommendation is that if you see something of this size and there is no enhancement getting into the internal auditory canal, then the person should have a surgery to get an understanding what kind of tumor it is. Is it a meningioma? Is it something else? Is it really a schwannoma? So that's my angle. And I think the primary care physicians and the neurosurgeons in Pakistan and many other part of the world need to understand the indications and contraindications, and when should they send patients for radiosurgery. And that's all. Thank you.
Okay, Dr. Abid, you were saying something on this?
Just one thing about the cystic vestibular schwannomas. Our experience has been that if there are multiple cysts inside the tumor, they respond. They show very good shrinkage. But if cyst is outside, like it could be a CSF cyst displacing, then that needs to be surgically intervened. But the cyst inside the vestibular schwannoma is not a contraindication for size.
Okay, thank you. So this was the post-SRS, which shows significant size reduction. And these are the other examples, again, courtesy of Dr. Kamran Saeed. These are the pre-SRS on the left and post-SRS on the right side. And it shows significant size reduction, significant reduction in the mass effect, and overall a size and the cystic nature here. You can see the significant size reduction again. Here on the bilateral acoustic schwannoma. So with this, I would like to ask Dr. Kamran Saeed on his experience with bilateral vestibular schwannomas. I mean, is there any difference in the treating a unilateral one and a bilateral one? I'm sure there must be difference in planning, and it must be a challenge for you to plan these cases.
Whenever I see a case of a neurofibromatosis 2 with bilateral acoustic, it's a very depressive feeling, but from my side, the patient not only have this bilateral acoustic, mostly of our, but we have come across our patients, they have multiple pathologies in the brain and then the spine. And it's very pitiful that majority of these patients belong to a very poor income group, and they could not go and afford multiple surgeries. For bilateral acoustic, the most important thing is the compression over the brain stem. If there is a significant compression from any right or left acoustic, we first do debulking surgery of that large acoustic to decompress the brainstem. Then we go and do radiosurgery. And the second important thing is that these patients have very poor hearing ability because both of their auditory pathway are being compromised. So second most important thing what we do is to deliver minimum dose to the cochlea. This we do in a very strict fashion, and we all know that even if we deliver a very low dose to the cochlea, these patients do very poor, poor, and with the passage of follow-up, we come across that there is the decline in their auditory function. So bilateral acoustic to treat them is not a good feeling, and it's very difficult to treat these patients. That's all.
Right. Thank you. So with this, we have already discussed, as Dr. Ather has already spoken on the utility or perhaps the misuse of SRS in low-grade glioma. So there is a case of a 21-year-old right-handed male, KPS of 90 presented to us with complaints of single episode of GTC. MRI showed a left frontal lesion and the typical of a low-grade glioma, non-contrast enhancing, and just anterior to the motor strip. So we did a awake craniotomy and maximum safe resection. It was a near total resection with some residual near the medial and the posterior aspect. So this case is only to discuss that for the low-grade gliomas, the role of SRS is still not very, is not very convincing. So Dr. Kamran, your experience, or do you get patients with gliomas referred to you for SRS, low-grade gliomas?
We never treat gliomas upfront with radiosurgery. We always, almost all of our cases were treated, but those patients who progressed after conventional radiation, we don't have any experience of patients treating upfront with radiosurgery of grade 1 to grade 4 gliomas. We only treat after these patients fail after conventional radiation.
Right. Dr. Milawi, what do you say on this?
For the low-grade glioma, as I was saying, so as long as the lesion is benign, and as you know, in glioma, the benignity of lesion can be questionable, but for benign lesion, pilocytic, of course, is a good indication because they are focal. In the diffuse low-grade glioma, is more complex, and I would say it will depend on the volume of the residue, but we had a small experience with this, with small residues in functional area, and the response is quite good as long as the lesion is still a grade 2. But as you all know, with time this lesion will tend to progress and to transform into high grade. So it may be an adjunct for this small residue to try to have or optimize the control. So in young patients, we have some cases, but very selected few cases, which shows some response. We observed volume reduction and control as for other benign. But again, the problem is not focal disease, and the benignity is a matter of time, and we know that with time these lesions tend to transform, so it's still an oncologic problem.
Right, thank you. So we don't feel like leaving this session, and we can have this discussion for hours and hours, and we are all enjoying this so much. But due to time constraint, we have to conclude this session now. So thank you everyone for the wonderful panelist discussion. Now I would like to request Dr. Ather for the closing remarks, and then we can conclude the session. Thank you, everyone.
Well, thank you very much. This was amazing 4 hours that I spent here, glued to the chair, because everything was so interesting and exciting. It started off with the innovations in mobile MRI, portable MRI, not mobile, portable MRI, and then talking about artificial intelligence, but the interesting discussion that we had and the interesting lectures that we had in the stereotactic radiosurgery. And as Dr. Waqas, you rightly said, you know, this discussion is so interesting, it can go on and on forever. I need to thank all those who helped organize this, and in particular, Dr. Waqas, Dr. Ahsan, both are our heroes in neuro-oncology, and then the biggest hero is Sharif Charania, who always arranges these things with help. And then now we have team with Mr. Sharif Charania, people like Mr. Usman and Ms. Sonia, plus the neuroscience interest group, which gives me that energy, that desire to live actually in this world, are these young people. And two of them were here to actually conduct this this session. And I see that NSIG, the Neuroscience Interest Group, is going to connect with more neuroscience interest group across the country and beyond the country. And by neuroscience interest group, I mean not only basic neuroscience and neurosurgery, but also neurology and other clinical neuroscience. I have to thank the collaborators who helped us in making this mini-symposium, which I was thinking about for a long time, come to a reality. And for that purpose, I'm thankful to Hyperfine, and I thank to Electa Allmed. So Allmed is the company over here that handles Electa, and they have installed that gamma knife in different part of the country. And to BMW, I think this is the first time that we have an automotive industry contributing to collaborating for a scientific session, but then BMW stands for perfection and innovation. So I think this was a perfect fit with disruptive innovators such as Hyperfine and the state-of-the-art treatment by Electa Allmed. BMW fits nicely in there. So my thanks to all these companies for supporting us and collaborating with us to produce this remarkable mini-symposium. And I look forward to having more mini-symposia besides the annual neuro-oncology symposium that I do every year. And the one that we are planning is in the first week of September. It will be all about brain tumors, and I'm sure all of you will be interested in joining that. So once again, thank you very much. And I don't think I forgot anybody to thank anybody else, because there's a whole, just like a child is raised by a village, in the same way, the conference is done by a whole group of people. So there are about how many? Okay, so we had about 1,000 online, so that was a great success from our perspective. We'll be analyzing the data that how many are from Karachi, how many are from Multan and other cities, and how many are beyond Pakistan. But that was very encouraging, and that is all because of the great speakers that joined us, that the audience wanted to listen to them. They didn't come for me, and Ahsan, Waqas, maybe not for you either. But those were the those were the speakers that they came for. So thank you once again. Thank you very much.